allowing me to be here again in the second time at the APCIS meeting. This is my disclosure. So let's start with the beginning of the story. As you know, that actually this is a very classic PowerPoint slide. That when you deal with the abnormalities of the RVOTs, you think about two kind of group of the patient. The first one would be the native or non-conduit, which is likely to become the regurgitated after years. And another group would be the patient with conduit, which is likely to have the pulmonary stenosis also together with regurgitation. If you talk about melody, you need to at least recognize this person, Philip von Hofer. So he is actually the father of this this kind of development. So it's published first in Man in 2000. So it's almost 16 years ago. And this is the first actually prototype of his work, which actually didn't work that time, but eventually it became this one eventually. So this melody now has been accepted as a CE mark approval, and also in Canada, and FDA just recently 6 years ago has been able to use throughout the US. If you talk about the venous P valve, definitely is developed by the Chinese doctor, and also the team from engineer. This is Frank. He's the only one pioneer engineer for this valve, and actually he works in the US, but he worked closely together with the Chinese team doctor. So the first implanted venous actually is not what we saw at the moment, but it is kind of the straight tubular part of cell expandable valve. The first one has been done by Dr. Q in Hanoi in 2012, with still having a very good result at the moment as far as I'm concerned. I talked to him just a few months ago. For the novel design, cell expandable with a flare part like this. So the exploring person in this area is Dr. Shilin Kao and also Siyat Hijazi. So the first in man implanted was done in Shanghai. Actually, now it's approaching almost 2.5 years, which still have been a very good result as well. So this is the real picture of that patient, the first one implanted. So thanks for Shilin for giving me this picture. So showing the profile of the valve, as you may notice that the Medtronic Melody is actually the balloon expandable stent framework. It's mounted with the configurable bovine valve with a CP stent. So length would be 28 millimeters, and it can be expanded up to 22 millimeter. So it's mounted with the balloon delivery system, big balloon, and they have the very nice, smooth, and a bit low profile of the delivery system. For the venous, they have two options. The first one would be the flare design. As you can see here, it's a unibody. It means all from here to there is one body, no connection at all. So it's cell expandable 19 frame. The part here tended to stay at the bifurcation of pulmonary artery, while the part here is intended to stay at the RVOTs. And the valve is a little bit lower at the lower 1/3 of the straight part of the body. And the largest diameter is 36 millimeter. And this is a system for conduit RVOT. As you can see, it's a little bit modified. Now they have 2 ears rather than just 3 hooker. And this one is also crimped under the sheet like this, and the maximum French size diameter would be 22 French. So for this thread design, they will have 16 to 30 millimeter valve diameter with the length here starting from 25 to 35. So let's show you a little bit in terms of the indication and implantation procedures. As you may notice that this is kind of strict criteria years ago for using the Melody. for treating the patient with dysfunctional conduit. So mainly indication at the first years will be strictly only the RVUT conduit dysfunction, and definitely the patient has to have the stenosis together with regurgitation of that conduit. But nowadays, just recently, there's a lot of report and also attempts to improve, to expand the inclusion or the treatment criteria of this melody valve to the native RVOTs, as I can show you from the PubMed search. So just to show you an example of how they're going to use the melody for the native RVOT. So this is, thanks for Shah Qureshi. So this is 25 years old, previously patched at the RVOT for pulmonary atresia and tach septum. So as you can see here, it's a little bit calcified here, but mainly is starting to have stenosis together with regurgitation. And the RV function is still okay, but about to be like significantly dilated from the, sorry, they didn't show you MRI picture, but that was indicated. So as usual, when we trying to implant the valve at this pulmonary artery position, we need to look very carefully on the pulmonary artery in relation to the coronary artery, especially left coronary artery. So in this particular case, with balloon occluded at the RVOT MPA, so you can see the coronary artery is a bit far, not a bit, but far away from the left coronary artery. So it's quite safe to implant the stent and also the valve. So then Shaq did implant the LV Max stent, and then eventually he implant the valve, the Melody 22 millimeter. And this is the final result of the valve, which is very, very good result. So how about the venous? If you talk about the flare design, actually the indication is quite similar, but we will exclude the patient with stenosis because this one is self-expandable one. So the radial force is not strong enough to open up the stenotic part if it's significant stenosis. So we're still trying to strict at the body weight over 30 kilo. It has to be non-conduit definitely with the symptom related to pulmonary regurgitation. And also if the patient has significant PR, I mean regurgitation fraction is more than 30, or the end-gastric volume index is more than 150, or the ejection fraction is less than 45. And we need to make sure that MPA diameter should not exceed 32 millimeter. The reason is we have to oversize it, maybe 3 to 4 millimeter. So the maximum diameter that we have is 36, so that's why we're trying to strict the diameter down to 32 millimeter. Definitely we need to make sure there's no significant obstruction, as I mentioned earlier. So we need to exclude also the patient with the short pyramidal shape of the RVOT because the valve cannot stay in place. If you have proximal stenosis or pre-stented RPA-LPA, we need to be very careful at the moment. We try to exclude it also. And definitely if you have a problem with the femoral venous access. Just to show you an example of how we're going to do it. This is not complete process because I think the time constraint, but just to show this is a significant PR without PS of the native RVOT. And then we insert the valve. But as usual, before we do that, we need to do balloon interrogation. I didn't put the slide in, but do balloon interrogation in order to see whether the relationship of the coronary artery and the pulmonary artery is okay or not. And also we need to know the expansibility of that RVOT. So that diameter is very important for us to select the valve. Then we implant it by putting into the delivery system like this, and then we slowly open up the valve by clockwise rotating of this knob in order to slightly release the valve. So here this valve is almost completely released. There. Okay, now it's completely expand, as you can see here. And this is a final angio. So with this technology, we don't really need the stent, pre-stented, because as I mentioned earlier, it's not it's nitinol is more expansive, more conform to the anatomy, and also it's less likely to fracture, what we thought at the beginning. So for the straight design, it's quite similar to the Melody valve, because we need to pre-stent it, and indication is similar. And just to show you example of how to use straight design, as you can see, this one is post-Racelli, very significant stenosis at the RVOT conduit junction here, and the patient has very bad ejection fraction together between both on the left on the right side. So as usual, we need to strengthening this part by putting quite a number of stents in order to make sure that we have a good landing zone, and then we implant the valve by putting into the delivery system, and then we slowly release the valve by clockwise rotating the knob, as I showed you earlier. So now it's completely uncovered. And this is the final result. The valve is quite nicely intact, functioning well. So let's talk about the outcomes. I have not no exact number of how many people, how many patients has been treated, implanted by the Melody, but from the website in 2014, at least 6,000 patients has been implanted. So it's quite a number. So how about venous? Now in China mainland, the original place that the valve has been born, is almost 50 cases implanted at the moment. And outside China, it's about 40 cases. As you can see, Vietnam is the first one, and then we did some of the patients in Bangkok, 1 failed, and 13 succeed. And in Jakarta, we did 1, and in India also, its number is now increasing here in India. And in the UK, Shah Qureshi did at least 8 cases now, and just 2 weeks ago, I think he did another 3 cases. And Dublin also, Kevin Walsh, and Chile, 3 patients has been implanted. So commonly used size would be like 32, 30. 32 stand for diameter, 32 millimeter. 30 stand for the length of the straight part, so 30 millimeter length. And mostly it's flare design. So in terms of the outcomes, definitely you can search this very easily in the Medtronic website, which is very nice compilation of the review. As you can see, mostly from European and some from the US, but none from the Asian countries. So in terms of the valve integrity, it looks very nicely, showing that there is no obvious stenosis after implanted even 5 years, and there is no obvious significant pulmonary valve regurgitation. So mostly more than half of the case has just no PR, and 90% of the case probably would be almost just trace and no PR, even 5-year follow-up. How about the venous? At the beginning, now we, thanks CC, Dr. Pimpak, she did review and collect the data from around the globe outside China. So what she found was the RV anesthetic volume index is starting from almost 146, and now 6 months is down to 110. And PR fraction is significantly, dramatically decreased. So in our series, we did implant now 13 cases. So as you can see, our endoscopic volume index remain stable, at least 1 patient reaching 2 years now, and still remain stable. This patient had a significant TR post-operatively, because we inadvertently pulled the valve back and touching the tricuspid valve, but this patient is quite stable even 1-year follow-up. And this is ejection fraction. It's quite stable from the beginning, and 1 patient is a little bit increased and then a little bit decreased. So I think it's not really because of the valve, but maybe because of the measurements, different between each study. And how about the PR? Definitely 2 months, 2 years follow-up, still okay, less than 10% for most of the patients. So in comparison to the adverse events of the Medtronic Melody, just to show you that strength fracture initially has been noticed because it's not pre-stented, but nowadays I think it's even less than this number. because they know exactly that we need to present the melody before we implant it. But one major concern of the melody will be the endocarditis. As you can see here, the incidence ranging from 2.4 up to 3.2, even follow up at 5 years. So this is the thing that around the world, I think they're trying to sort out what is or what are the reasons why it happens, but still on the way to explore. So how about the venous? So maximum pressure gradient now, the maximum patient that we had was about 30 millimeter of mercury, and we had trivial PR in 2 cases. We have moderate TR in one case, as I showed you earlier, and still, knock on wood, no endocarditis. But as you can see, we do fluoro follow-up. We do MRI follow-up at 1 year and 2 years, and we do echo follow-up as usual at 1, 6, and 12 months, and then another 12 months. So what we found was we had 4 patients had a fracture of the single Y here. So it's very delicate, and it's likely that you're going to miss if you not clearly or carefully have a look on the fluoro, because this patient has been shown here. So fracture is actually there. Sorry.
Worakan, one more minute to go.
Okay, thank you. Yeah, so most of the fracture stent, the framework is still intact and functioning well. So in conclusion, ladies and gentlemen, I would like to say that Medtronic is balloon expandable, while the venous is self-expandable. It's bovine jugular vein for Medtronic Melody, and its venous valve is a Promphan pericardium. Intended to use initially for the Melody would be the conduit case, but venous, it's both native and conduit case. A maximum diameter is about 22 or 36, depends on which valve you want to use. Now it's ongoing process for CE mark trial for venous, but it has been approved by the Canadian, European, and the US to use this regularly. Just less than 100 cases implanted at the moment, and the Melody has excellent outcome, a part of the endocarditis, and the cost definitely will be an issue. So at the moment, the venous is not commercially available, but I'm not sure whether in the future the cost will be affordable for our Asian countries or not. So thank you very much indeed, and most of you are welcome to go to Bangkok next year. Thank you.